So gallbladder disease, there's kind of two subtypes. You can have cholelithiasis, where you have stones in the gallbladder, and then you can have cholecystitis, which is inflammation of the gallbladder, commonly associated with gallstones. Gallbladder disease is actually a pretty common health problem. Risk factors include being female, older age, estrogen therapy, sedentary lifestyle, and it does tend to run in family, so a little bit of a genetic component, and then also increased risk with obesity. The cause is generally unknown. It can develop when the balance that keeps cholesterol, bile salts, and calcium, when that balance is kind of disrupted, and it leads to a precipitation, and then the bile secreted by the liver becomes supersaturated with cholesterol. And then you have the stasis of the bile, which leads to, again, that supersaturation and then ultimately like a biliary sludge. Other factors that can contribute this, immobility, pregnancy, certain inflammatory conditions, anything that's going to decrease the flow of bile. So with cholelithiasis, the stones might stay in the gallbladder, or they could possibly migrate to the cystic or common bile duct. When they do pass, they are extremely painful, especially as these stones get lodged in the ducts and cause obstruction. So you can see here we have a gallbladder that is just filled entirely with gallstones. With cholecystitis, again, this is associated with inflammation. It's often also associated with obstruction from a stone or that biliary sludge. Again, very common in older adults, critically ill, anybody with prolonged immobility, and other conditions that could possibly cause biliary stasis. With cholecystitis, again, this is inflammation. This inflammation can be confined to the mucus lining or the entire wall of the gallbladder. So you have a gallbladder that becomes edematous, and it may even become distended with that bile or pus drainage if it becomes infected. And then long term, we worry about scarring and fibrosis after one of these attacks. Clinical manifestations, they really vary. So patients might have pretty severe complaints, severe pain, to really no pain at all. The pain does become more severe as the stones move or cause obstruction. Other associated symptoms that you could expect, tachycardia, diaphoresis, especially if the patient's in pain. Patients typically have right upper quadrant pain, that's where the gallbladder is located, and the pain can be worse 3 to 6 hours after a fatty meal or when the patient lies down. Remember, the whole function of the gallbladder, it produces and stores bile. Bile is secreted to emulsify fat. It breaks down fat. So if you consume a fatty meal and your gallbladder is not working properly, it can't secrete the bile like normal, that could definitely cause a flare-up of the pain. When total obstruction occurs, this can cause amber-colored urine, even clay-colored stools, pruritus. We talked about the intolerance to fatty foods because of the lack of bile. And then statorrhea, that's just another term for kind of fatty stools. In addition to pain, patients might struggle with indigestion, fever, especially if infection follows, possibly jaundice. And sometimes that right upper quadrant pain can be referred to the right shoulder scapular region. Patients might also have issues with nausea, vomiting, all things like that. If we are concerned about infection, you could possibly expect leukocytosis, an elevation in the white blood cell count, accompanied by fever, and then the right upper quadrant or the epigastric type tenderness, and the abdomen might even become kind of rigid as the inflammation progresses. Complications, we worry about gangrenous cholecystitis, abscesses, pancreatitis. So the pancreas is located closely to the gallbladder. Some other biliary issues, fistulas, and then if the gallbladder ruptures, this could lead to peritonitis, which is infection of the peritoneal cavity, and that can progress to sepsis very rapidly in septic shock. So how do we diagnose cholecystitis or cholelithiasis? Usually ultrasound is going to be sufficient enough to diagnose gallbladder disease. There's also ERCP and percutaneous transhepatic choleography. But again, ultrasound usually our first line for diagnosis. We would also want to obtain some lab results. You can usually expect elevated white blood cell count, maybe increased levels of bilirubin, alterations or increased levels of the liver enzymes, or maybe even serum amylase. Our interprofessional care involves controlling infection if possible. So these patients are going to need antibiotic therapy and maybe NG tubes placement for very severe nausea and vomiting. If they undergo a if they have their gallbladder removed, this can be painful, so we want to treat their pain, maybe use opioids. And then anticholinergics can also be beneficial in that they decrease GI secretions and counteract that kind of muscle spasm from the smooth muscle. There's a couple different surgical interventions that can be done, laparoscopic or incisional cholecystectomy are the two types of surgeries. So laparoscopic is going to be our treatment of choice. So it actually removes the gallbladder just through 1 to 4 little puncture holes. So it's much less invasive than traditional like open incision cholecystectomy. Minimal post-op pain, patients can return to normal activities very quickly, and it's associated with few complications. So the surgical treatment of choice for the patient with symptomatic gallbladder disease is, I'll let you read through those. And we know this because we just talked about it. Our answer is D. The laparoscopic cholecystectomy is our preferred treatment. As far as nutritional therapy, small frequent meals are going to be best, preferably with just some fat, kind of a low-fat diet, definitely low in saturated fats, high in fiber, calcium. If the patient's obese, good idea to reduce the calorie count, but we still want to avoid rapid weight loss. So we have another question. Postoperatively, a patient with an incisional cholecystectomy has splinted respiration secondary to high abdominal incision. What action should the nurse take first? A. Assess heart and lung sounds. B. Administer the prescribed analgesic. C. Position the patient on the operative side. D. Instruct the patient to cough and deep breathe. So this patient's had an incisional cholecystectomy, which is different than the laparoscopic. It's much more invasive, and now they kind of have these splinted respirations because of that abdominal incision. So they're not taking their big deep breaths, probably because it hurts. So what is the first action we should take? And if you chose B, you were correct. So this patient was struggling with not being able to take big deep breaths because that incision, it was painful. Every time they take a deep breath, it hurts. So the way to fix that is to give the prescribed analgesic medication. It's very important that patients are taking big deep breaths and coughing, especially post-operatively, to prevent atelectasis, which can then turn into pneumonia. So very important to prevent those post-op complications. As far as our nursing management, health promotion, for sure, screening for any kind of risk factors, teaching at-risk groups, and then early detection. And if you have a patient with chronic cholecystitis, definitely want them to be on a low-fat diet. Other acute care nursing goals: treat the pain, manage the nausea and vomiting, help provide support, maintain normal fluid and electrolyte balance, and then also keep a close eye out for complications. We talked about how we will give analgesic medications. You also want to treat the pain before it becomes severe. So ideally, we're treating before it becomes a 10 out of 10 pain, so you're not having to play catch up as far as pain management. We definitely want to stay on top of their pain management. We talked about how patients with severe nausea and vomiting might need an NG tube for gastric decompression. So be aware of the suction and obtain adequate and accurate intake and output measurements. You can give your antiemetics like Zofran also to help with nausea. If your patient's struggling with pruritus, we could give antihistamines, topical lotions, certain baths. Also want to make sure your patients have short, clean nails, especially if they're scratching. And then again, we're monitoring for complications. This includes obstruction, bleeding, and infection. Post-ERCP, again, assess for complications, keep a close eye on vital signs, bed rest, keep them NPO until their GAD reflex comes back, and then patient education is another important aspect. And then your post-op care for laparoscopic cholecystectomy, again, this is going to be very similar. The difference here is most patients recover very quickly because it's less invasive. They only have those 1 to 4 little puncture sites. Advance their diet slowly, start with clear liquids, but some people are even discharged the same day. With your incisional cholecystectomy, again, this one's going to be a little bit more intense, so a little bit longer recovery period. Preventing respiratory complications like atelectasis and pneumonia is huge here. So medicate your patients, treat their pain so they can cough and deep breathe. And if they do have a drainage tube at their post-op incision, we want to manage that as well. JP drains are fairly common as well. And then our ambulatory care, focus on low-fat diet, weight reduction if that's applicable, and then sometimes they need supplementation with fat-soluble vitamins. With laparoscopic cholecystectomy, they can actually remove their bandages the day after surgery and then they can shower. So very quick recovery time. They just need to be aware of any potential signs of infection and to report those. With the open incision cholecystectomy, no heavy lifting for 6 to 4 weeks, and they're going to need a low-fat diet for a longer period of time.